Welcome to Leadership and Culture and Healthcare. I'm Matthew Wynn, podcast host, and we're on to the next episode of talking about mergers and group models. And I'm delighted that James Sumner from the University Hospitals of Liverpool Group is joining me. James, welcome to the podcast. And why don't you just introduce yourself, what you do, and then start to tell us a little bit about your really interesting group in the Liverpool and Cheshire world.
Thanks, Matthew. Nice to be here. My name's James Sumner. You just said I'm from the northwest patch. Been around Manchester and since Cheshire Mersey now for a good few years. I've been in the Liverpool patch now for 3 years. And what we've been doing there is effectively just trying to work through what a strategy looks like for the population of the city, which is highly deprived and got a lot of social issues, as you're probably aware. And also the sort of configuration of specialist services across the broader ICB patch in the northwest. And what we've got is this really interesting situation of a highly deprived population, excellent specialist services, but these odd situations where people, when they get into that sort of secondary tertiary space, get a really good outcome, but a lot of them don't get there, and they don't get what they need locally. So we've done a lot of work with the sort of population segmentation analysis, looking at what that population really needs, and it gave us sort of three really clear indications. And one of those was the acute and specialist hospital landscape needed aligning properly. We're fairly unusual in that we had 5 hospitals, foundation trusts, all in the centre of the city, mainly connected by corridors or bridges and sharing car parks, but separate institutions. And obviously over a long period of time, that served organisations well in the foundation trust era for lots of reasons and been financially beneficial. But over recent years, post-COVID, you can really see the fractures and the split in that sort of financial allocations, tariff issues. But you could also see organisations with 5 different strategies sort of ending up with 5 different digital systems, ending up with 5 different ways of doing things. And it was becoming increasingly complicated for patients. So that was something we really needed to address. Beyond that, we found as well that our population analysis showed us that certainly in Liverpool, and I suspect in many places, primary care were really struggling, as were the local population, to find an alternative to either ED or a very long wait for an outpatient appointment. And what we really need to think about and are trying to do collectively is think about a different model for sort of diagnosis and treatment rapidly for people, and a different offer for GPs around that. And then the third bit, obviously and inevitably, is that neighbourhood level care hasn't got to where it needs to. And as a set of organisations, we don't see ourselves as the leaders in that space, but we do see ourselves as working with other partners in the city like Mersey Care and Alder Hey, who aren't part of this arrangement, in a much more collaborative way to look at how we do things differently around that offer into certainly community and supporting neighbourhoods and practices at scale. So that's where we knew we had to go. So the group model was effectively one way of saying, well, look, we've got a provider collaboration in place between the 5 trusts. It's got us so far. We've done some good things to date. But what really drove the move to a much more sort of structured model of single board, single oversight, was the fragility of the women's services and the maternity hospital. And what we needed to do was provide acute and specialist support to women in what is effectively a very isolated site that was financially challenged. So the women's hospital joined what was previously known as Liverpool University Hospitals, the Aintree, Royal and Broad Green Hospitals in Liverpool, who are the acute and specialist trusts. So the Liverpool Women's Hospital joined, and that's where this sort of UHL group was born, really. Subsequently to that, I've become the chief executive of the Liverpool Heart and Chest Hospital. And then we've got 2 other hospitals who have their own boards and CEOs, Clatterbridge Cancer Centre and the Walton Centre, who are scheduled to join the group over the next year or so. So we're all working together in a collaborative arrangement now, but that sort of hardwiring of single boards and then single leadership teams that sit across these organisations and report into that structure is sort of where we're at.
And so for those, and I don't know Liverpool that well, but it occurs to me that therefore one big district general tertiary hospital, which is the original Royal Liverpool, isn't it? it's an unusual arrangement in any geography for so many kind of specialist elements to be just in one separate organization. What is there a reason why the area went for that type of approach historically that you're now kind of unraveling somewhat?
I think this goes back a long way right back to the sort of Foundation Trust era when
Right.
the Foundation Trusts were first brought about. I'm not quite sure exactly why it happened, but there was certainly seemed to be a sort of badge of honor system in Liverpool to be an FT and to have an FT. So for whatever reason, things were sort of slightly disaggregated at the time. We also had changes that have happened over the last few years. The Clatterbridge Cancer Hospital was over in the Wirral and moved into Liverpool to be next to the Royal. Because of clinical adjacencies that were required. Aintree Hospital has been there a long time, previously known as Fazakerley, and the Walton Centre for Neurosciences moved to that site to link up around stroke and trauma. So it's just a sort of historical thing. It is different. It's very, very different to other places. What I would say is there's been lots of benefits to the separation of those specialist trusts as well. So Cheshire Mersey recovered very quickly post-COVID, for example, in terms of getting cases done in specialist surgical cases, because it had those separate hospitals with separate critical care units that weren't affected in the same way. So there's real benefits that we want to retain in this model going forward. And we're very clear that our patients know and love those organisations that they know by name, and we're going to retain all of that as well. The brands, the identities of those hospitals are important to patients, important to staff. So what we're really trying to do here is for this sort of group effectively to be more of the background corporate services and strategic planning side of things, rather than the name on the letter that patients receive. They're used to these individual hospitals in Liverpool, and we don't see we need to change that.
Yeah. And I remember just on that, I mean, the very first podcast I ever did on leadership was with Jane Tompkinson, because she was because it was on the staff survey results, and of course Jane was chief exec now over at Cantor Chester and working hard to pull that organisation around. She was at Liverpool Heart and Lung, wasn't she? And I remember her saying it was kind of easier because it was a relatively small organisation. She could really get as a CEO her hands around the organisation, and the staff loved that. But that's a real privilege in some respects, but as you say, probably has had its day in terms of a model and the effectiveness of that and the cost effectiveness of being able to maintain that level of corporate support.
Yeah, there's definitely something about the sort of size and scale issue, because you've got sort of district general hospitals with specialist services in them at Aintree and the Royal that are sort of 600 million scale, and then neighbouring organisations that might be sort of 150 million scale. But what's really important, I can say this having taken over at the Heart and Chest now, what Jane has done there over many years is really embedded a culture of learning and quality improvement and pride, and it's a fantastic organisation.
Yeah.
So we've got to be really careful not to unravel that stuff, because that's what makes it what it is. And I think what we're trying to do, and what we've seen really work well in the model that we have, and everybody does this differently, I get that, and is that we have a sort of hospital management board that effectively runs the organisations, the hospital sites or the collections of hospital sites. The executive managing director is a voting board member of the group board, but they have significant autonomy, and I mean real significant autonomy in that sense. So that's where the business is done, closest to the patient. And the group function and my role is much more about almost knitting together the strategy of trying to create some consistency in terms of the direction of, say, digital, in terms of what we might want to do around research and innovation and those things, rather than getting involved in the day-to-day running of these organisations, which are different. And I suppose we'll get onto this as we go, but the immediate question is, what do you do about sort of driving a culture and values in strategy, if you like, within an organisation that's born of so many different parts? And the answer to that is we don't really want to upset that. We want to try and gradually bring that together by looking at what's common, but certainly not unravel some of the great things that's already there in all of those organisations.
So just for people listening, and this is, we've done quite a few episodes on this series, and every group is different in the NHS in England. So you've got management teams with exec leads, medical nurse directors, the kind of a quasi kind of board there, but it has, I assume it hasn't got non-executives. You've got a single set of non-executives at group level, so therefore they're overseeing the functions of all the existing statutory organisations, but that's been moved up to that top level.
Yeah, that's right. But there's two fundamentals for that in the way that we do things. One is that when the organisation's of such a scale, it's my belief in how we do this stuff is that we run our organisation through risk effectively. So there's two ways of doing this thing from my perspective. One is you either replicate the way that you would run a normal hospital at every level, and everybody has a quality committee and a finance committee, and then there's another one that sits above that and brings all of those together. And when I got to the organisation and we looked at how it was intending to run, and we counted that up, and there was something like 30 to 60 meetings a month that eventually land in this sort of top of the pyramid. And
that would be a joy for anyone, wouldn't it?
Yeah, well, exactly. Yeah. And you can't do things that way. So you got to be able to delegate that autonomy. Now, for NEDs, that's really difficult. And when we started, and with the board in particular, it was, how are we going to get that assurance? So all of our management boards are effectively risk-led. So they run their management boards like you would an existing trust board meeting, but their primary focus of those boards is receiving assurance reports from their quality and safety and performance meetings that they have. But it's very much driven by their risk registers. And what that allows us to do as a group board is within our meetings with all of the hospitals, what we get is predominantly, here's what we discussed at our board, the assurance levels, here's our key risks and how we're managing them. And we can triangulate that with the performance scorecards for that site, their improvement plans, and so on. But what's worked really well for the organisation is just focusing on risk and managing risk constantly, because it allows us to cut through what would be an inordinate amount of information and really just get to what are the principal risks that are facing that organisation. Now, to do that, we've had to put in place really rigid corporate governance. So these individual management teams are not allowed to change that governance. They're not allowed to mess with the way we do risk scoring. They have to run their management boards in a consistent way. But then every other decision is theirs. And the only rules that we have in place around that are that we have what we call our sort of five rules, basically. And they're things that nobody can do in isolation of a conversation with others. So we moved away from this whole permission, here's the manual of how you do things around here. And we said, you can do whatever you need to do within delegated limits. But you can't go and change digital systems without speaking to the rest of the group. You can't go and change the way we count activity. You can't change the structural pay rates for staff without a conversation. So there's 5 simple rules effectively that we employ. And once a month, we get all of the hospital management teams together with me and my executive team. And we effectively just go through the corporate risk for the whole organisation. And we understand, has anyone got one of those rules they need to discuss? And someone will say, look, we've got this situation in theatres here. We think the pay rates are wrong, or whatever they might be, or we think the banding are wrong for these staff. We need to do something about it. But if we do, it's going to affect Aintree as well, or it's going to affect the Walton test. So we'll need to do that. And that served us very well in the sort of 18 to 24 months we've been running that system. Touch wood with this stuff always, but we've never since had a risk that we weren't aware of, a significant risk that we weren't aware of. And we used to have those daily, almost, it felt like at the beginning. And secondary to that, we've managed to really radically improve the organisation's governance from a CQC perspective. We've gone from inadequate to good and well-led in one leap, and we've gone within the sites themselves. They've turned their urgent care around from inadequate with significant legal concerns and Section 31s to good in one go. And all of that's been about strong local leadership, but really clear risk management. And I think that's what works for us. The obvious question is, will it work at something that's even bigger? And can you keep replicating it? And where do you learn from it? And there's a risk that you step into outstanding organisations like some of these others that we're working with now, and try and put your model into something that's already working well. So we're just thinking our way through that.
And how hard was it, therefore, to flip that approach to then be focused on risk management? Because lots of NHS organisations, and I slightly characterised, but slightly accurately, I'm sure, have the risk register as something they nod through or they have at the end, and it's something to note. What you're describing is a active, accurate, live, useful tool that actually is focused on mitigation and I presume kind of escalation points where different people need to be involved for different purposes. So how did you get people to kind of become to that approach and take that seriously and get that right?
So the first thing was really making sure that people understood how to understand and calculate risk. And that went from how do we use a scoring system that was different to the one the organisation used to use. They used to use the 5 by 5, and we now use a 5 plus 5 plus 5. So it takes that sort of controls into the calculation. We had to retrain all the staff as to why we needed to do it that way and how we did it and how to calculate it. And then we had to endure, like you do when you do this in organisations, because I've done it in a few now, the first few months where everybody thinks that if they make their risk the highest risk, they'll attract funding or attention or whatever it might be, and deal with that appropriately. And then what you get quite quickly is a very different view of, say, a hospital site than you thought you were going to get. And if I reflect back to starting at what was then Lough, so Aintree and the Royal and Broad Green, the immediate risk that suddenly flooded the risk register were all around the dental hospital at the Royal site. And I'd been there 6 months and nobody had mentioned the dental hospital. It had an outstanding CQC rating. Nobody had said anything about it. I visited it looked great. But suddenly we were finding all sorts of infrastructure risks over there that had the potential to harm patients. So some significant stuff around water quality, around heating, and around all sorts of stuff. And then we started to get risks coming up around infrastructure of the new Royal Hospital that was just opened, and water quality around dialysis. And I'm saying all these things, they're all in the public record because these risks are presented at our board. And when those things land, there's an immediate sort of reaction from the board to say, okay, tell us what your controls are, what you're going to do about this, and how it's going to be resolved. And then what we see every month from each of the hospitals is these are the key risks that we've been managing. And the board gets a real flavour of, are the controls having an impact on these risks? Or are we sitting here in month 6, still looking at the same risk as month 1? And what we see is more often than not that those risks are getting really well dealt with. Now, what we then do is employ the other tools that you've got in your kit bag, like internal audit and other things as well, to say, we had a risk that was here, it's been resolved and it's now here. Can we go back and have a look at whether it still really is, and just keep checking that out? And the corporate governance team effectively run the architecture across the hospital. So the same team effectively run the risk reporting and the meeting reporting structures, minuting and actions for the whole group. So we get a really consistent level of reporting. And that works for us, or it has done so far.
And then, James, you talked about the need and absolute requirement to have a local flavour. You know, people know that hospital, people know Broad Green, they know that one, etc. How far have you gone then in shared leadership, clinical leadership across sites, as opposed to really great uni leadership around a certain site? Have you gone into that, or is it still about a different site?
That's where we are now. So we've got the first ones of that will emerge. So like the Heart and Chest Hospital actually shares the same hospital site as Broad Green Hospital. And in fact, it is one hospital. It's just got 2 different colours in it. So you can push a patient from one end of one to one end of the other, but they are separate foundation trusts. So what we've done there is almost said, well, look, it's nonsensical when you look at the opportunities here around shared estate, shared diagnostic services, shared therapies, shared outpatients. These facilities, interestingly, for example, we've got situations where there's 2 MR scanners in the radiology department. One belongs to one hospital and one belongs to the other. And you queue for this one or that one, not whichever one's got the best capacity. So those things are easy to say, but tricky to resolve when you've got what will effectively now be a leadership team for that whole hospital site, but effectively 2 separate statutory sets of accounts. So how do you manage that financial envelope? Now, we're just working our way through that, and we think it's all possible, and we can do that. And we've had experience of obviously operating the group with two trusts within it, because Luft is one and the Women's is another. And we actually disaggregated the Luft Trust back to the Royal Aintree Broad Green, in a sense, with leadership teams sort of looking after those. So we've had to already sort of rework how we build up the financial position into these separate entities and so on. So the key there again is making sure that we use the same risk reporting system, we use the same corporate governance reporting system, the board gets the same information and presented in the same way. But we're yet to sort of trial and anger exactly how that's going to work across the two. What we do, though, already is within our group model, a single hospital within that group can manage and operate services across multiple sites, and we have that already. So Aintree run orthopedics across 3 hospitals in our group, and they're accountable for it. And it's very clear if there's an incident in orthopedics out of the hospital, it will be Aintree who carry out that investigation around what's going on in orthopedics with that hospital management team. So that works in the most part. We've still got some things we're ironing out, but that works in the most part. So it's complex when you try and explain it, but once you've been working in it for a little while, it actually does make sense, and we think works pretty well. So this sort of leadership across more than one hospital is the next test row.
And I presume at some point that just develops according to the specialism you got around. I'm assuming the heart and lung hospital are tertiary providers and therefore probably have some opportunity to provide clinical leadership for where you're doing other heart stuff in other hospitals and cardiology, and you get that networking approach, but that takes time. You can't just make that happen.
No, exactly. And I don't want to make sweeping generalizations around the difference between hardwired governance and provider collaboration, because there's good examples of both, isn't there? But all I would say is in Liverpool, we've had cardiology partnerships across the Royal and Aintree and Heart and Chest for a decade or more, but they haven't led to consistent service provision. They've still led to perhaps organisations trying to outbid each other for services or equipment or the provision of specialist things, and that isn't really how we should be working. So it's interesting, since I've come into the Heart and Chest Hospital, suddenly having really productive conversations with people in cardiology, also in respiratory, about why have we got these different services all a mile or two apart across the city, when we've got these big challenges and we really should be doing this differently. So it sort of feels like that sort of collaboration message is really hammered home. But it's helpful when there's a single decision-making entity who can say, right, well, that's what we're going to do.
And I think that's one of the rubs across the whole of the NHS, isn't it? I think you've described that really well, that sometimes these things are clinical networks, but if they've not got a purpose and a joint accountability or a common accountability to make that change, it's easier sometimes not to do it, isn't it?
It is, absolutely. And those decisions, I think a great example the other day, without getting into loads of detail, but around some of the really complex surgical stuff that happens at the heart and chest, which is quaternary work, really complex aortic surgery, and they need the vascular team there, and they want to be the first place in the country to have a sort of specific aortic vascular on call, but it will cost 350,000 to this organisation, and it's not in their financial plan, but it will put a 350,000 in this other one. And they're both under the same leadership now, and yet separate financial accounts. So we're sort of saying, well, come on, it can't be beyond us to do the right thing here, because the net position is zero. Why wouldn't we do that? So this is what we're trying to line out in this, particularly in this financial climate. Getting the right things done when people are under so much financial pressure is almost impossible. So trying to sort of say, look, there's a single financial view here. We've got to be careful about how we articulate that in accounting practices. Of course we have, but let's not let that get in the way of the right decisions, because there's some simple things we could do.
Yeah. And make that change and take the risk on those things. James, as you were talking, it kind of struck me that you've got a lot of moving parts in this group. It's a fascinating group, isn't it? Because you've got different elements. You've described all your different aspects. And it may be lots of hows, but how has it kind of come together to actually be what is sounding a really coherent group in terms of how it operates? Is actually the genesis, as I think you mentioned, some of it was some one organization helped another and then it developed, but making, boards stepping down, trusting someone else to do their work, going into single teams are big, massive cultural shifts that take a lot of leadership and take a lot of foresight to actually say, no, we're going to do this. So just give people a kind of view of how some of those things actually happened if they're thinking of embarking on this approach.
So, there's a healthy dose of two things. One was sort of instruction from elsewhere, and one was really just that, what is it that we're trying to deliver here? What is that case for change? What is it that's going to make the difference? And there's always a healthy skepticism around external reviews, because Liverpool's had more external reviews than anywhere I can think of. We've probably got the best described problem in the world, but it's almost there was another external review that triggered a sort of another conversation with a different group of people now than the past, perhaps, that said, look, we can't ignore the fact that we've just got multiple versions of this in the same place. We can't ignore the fact that our corporate service costs are too high because there's 5 sets of them within a few square miles. That we can't ignore the fact that digital systems don't report results back to people when they go from one hospital to another, and this just isn't right. The sort of healthy dose of instruction, of course, was that the failure to sort of deliver some of that from a collaboration point of view over previous years, I think, meant that NHS England, and in particular the ICB, decided that if we couldn't get our act together on that, a different commissioning strategy might be found, and that sort of nudged people along. But I have to say, the key with all of it has been just getting in the room and bringing it back to, well, what can we actually do here that's going to make a difference? What can we actually do that's going to help? It was triggered in a way by the fact that when I arrived at Luft, which was the original, again, Aintree, Royal and Broad Green, 2 really big district general hospitals, busy city hospitals, and then a smaller one, all sort of inadequate, well-led, all massive challenges with CQC, all in turnaround on performance. We were just flagging as the top of the list, basically. And when I arrived, there'd been a sort of interim team in who'd started to move it to, this thing's just too big to get a grip of. Let's start having some local leadership and at site level. And that had been started, but not quite finished, obviously, because of the timing. I'd come from working in a group model over in Manchester that was an emerging and new group. And there was some stuff I learned there that was really helpful, and made me sort of think about, I'd want to approach things in that way. That risk approach, for example, came from how they did things there. There was also some things I learned and was frustrated about there, being a leader of a hospital within a group, that I was determined not to put in place here. So we started on that basis. So we actually started with a group model within a single merged organisation, because it was the best way to discharge the responsibility to turn those services around. And when that was effective and it worked, I think what that did was, for regulators and for commissioners, was almost well, hang on, this seems to be working now. We haven't previously been able to turn this problem around in Liverpool, in these hospitals. And there's now some challenges at the Women's Hospital. Let's see if the same model can apply. And it really has. We've again, bringing in what were an excellent team at the Women's, but the scale of the organisation, the financial position of the organisation was just making it so hard to get anything done. And the only things we've really put in place there are that risk-based model, the corporate governance support, and the way we do the improvement plans. And that team, who are leading the Women's now, have just made some remarkable improvements in the last year. I mean, fully staffed maternity unit in the centre of Liverpool for the first time. Really good recent CQC inspection. So it feels like we've been able to try and test and prove the case over the last few years in a way that's then got others thinking, well, actually, there might be something in this. And what's interesting is with the specialist trusts, is that everybody will have a slightly different reason for wanting to be part of that going forward. The impending financial doom, always gets a fire lit under people, doesn't it? Because it's hard to get there on your own, and shared corporate services and digital services and things like that will help us bring costs down. But actually, there's very different perspectives on other things like sort of research innovation and particularly commercial opportunities. Clatterbridge Cancer Centre are really good at that stuff. And what we found is that we can all really, A, learn from them, and B, they can help facilitate, a rapidly expanding commercial program across our organisations because they've got the skills and experience that the rest of us didn't have. And there'll be examples of that everywhere. So I'm really sort of keen on this, how we learn from the best within that space as well.
And which is a fascinating kind of thing of making a change in how you structure, improving the outcomes, confidence then flows in, doesn't it? And that then breeds success. And when I say that, it sounds super simple, doesn't it, as a concept? But actually, that is true. Actually, that's kind of what's kind of underpinned all this, isn't it?
Yeah.
To allow you to then flourish.
Yeah, and we're not good at everything. We've still got big challenges. We've still got massive problems. But we're I think on this journey of continually improving, and that's always been from the outset what we want to do. I then arrived at Heart and Chest Hospital a couple of months ago and see how well embedded quality improvement is there. And I want to see that now in all the others.
And their staff support and their survey results are out the park, aren't they, in terms of what their staff saying. Yeah. So amongst all that, you've arrived, James, you've developed all this. What does a group CEO do then? Because you've already described that you delegate out, you trust your leaders, you've got leadership teams, you look over the top. So tell us a little bit, for those that kind of don't get this, what's the kind of essence of a group leadership role that you're undertaking versus other kind of more traditional chief exec roles? And I guess how have you adapted to that as well?
I spoke to an aspiring CEOs meeting the other week on this topic, actually, because partly I wanted to speak to them when I was asked, because I kept hearing that I was being accused of taking the jobs that were ideal first jobs for new CEOs. And I get that, actually. That is a real issue in the sort of scale changes in organizations and how you get into your first CEO role. So I do get that. And I was trying to talk to them about how I think these sort of group exec managing director roles are the perfect foil for that, because you've got scale and complexity and you've got your own place to run, but you've also got the sort of safety of a broader organizational support. But I think the key thing is, if, from my perspective, and all groups are different, the group CEO getting involved in the day-to-day running the organization is probably the first mistake you can make, because of the scale and complexity of it, the local flavor to it, and staff want to look up in their organization and see a team of people on a corridor in their building who they can go to and say, there's a real problem with this and I need your help. And that's what we wanted to sort of foster here. So what that then leads to is almost my job has become much more around the sort of future strategy of the organization, trying to manage the politics, which again in Liverpool's an interesting one, in terms of how you get from A to B with all this stuff, because there's so many people who want to have a view. We've got local pressure groups, obviously politicians, we've got this politics with a small p of other organizations. Then there's the whole, how can we sort of create the evidence base for that longer term plan of 5 to 10 years rather than this annual cycle that we're constantly stuck in. And a lot of what I do is really trying to provide just that support to the teams, the executive teams on the various sites, or the exec team that span the various sites, on how we're going to move to the next stage of development. So, in the last 3 years, that started with digging our way out of a really difficult problem in the beginning, learning to sort of get our stabilizers off, if you like, to then thinking about how we can do things that are different and start to really focus on some of the research, innovation, commercial, digital agendas that are difficult. And a lot of my time is spent really in that sort of provider collaboration space, which is look, we've still got separate boards in organizations here. We need to keep us all on the same page. Communications is a massive part of it as well, trying to get consistent messaging into organizations who've got different leadership models at the moment. So a lot of it's that. And the bit I miss, I said this again to that group the other week, is it's very different to my previous role, which was being a CEO in a sort of medium-sized trust that I could walk around in a day. I knew everybody's name. And I think the big problem with the role, and this will be different for different characters, I know, is I miss that sort of connection with frontline staff in this role in the way that I had it in previous ones. And you almost need to make sure that that's constantly topped up. Otherwise, you start to spiral into the sort of the bureaucracy world, or the bureaucratic world of just constantly being in meetings and never seeing anybody who treats patients. And that's really scary stuff, or it is for me. So some of what I do is that, trying to get out there and see what's going on and go and work with staff. And every organisation that I've sort of come into as an accountable officer, like at Heart and Chest Say this next week, I'm out there with the surgical division. I'm out there looking at what they're doing on the shop floor, and I'm trying to learn what that organisation does before I then step back into being a bit more remote and there being a local team accountable. So I don't know if we've quite got that right. I often reflect on that, to be honest. There's lots of times I think we haven't quite got that right. But it is a different role. It's one that's difficult to characterise, I think. And we hope over time, if the plan goes well, that you turn a few things around, you get to stability, and then you really want to get into that exciting space, don't you, where you're doing stuff that people aren't doing elsewhere, and you're trying to break new ground, and that's where we all want to be. It's hard yards at the minute.
And I'm sure you'll get it right when your teams tell you to butt out and leave them to it, because that's probably a success factor, isn't it? We've got James, go away.
One of my exec managing directors the other week, I won't name them and I won't name the specific item, but basically was dealing with an issue that had huge financial consequences and were in place. And somebody mentioned it in a meeting, and I said, why the hell are we paying for that? And this person just turned around to me and said, it's got nothing to do with you. I just went, oh, yeah, you're right. Actually, it hasn't. Yeah, I'm on top of that. It's got nothing to do with you. But fine. Okay, that's not your job. You're over there.
You're over there. Going through your bit. So I'll do my bit.
You need, but that is the key. And I think one of my big worries with these is that unless the accountability and the devolved accountability to those roles is as close as you can get it to a CEO role with that support, they're not attractive. If they're not attractive, you won't get the right people. Yeah. And if you don't get the right people, it won't succeed. And we've been very lucky to get people who are prepared to take a gamble on it with us and have then really blossomed in these roles, all of them. But that pipeline is critical. And because I know the people we've got will move on to CEO roles in groups or other things in their own right in the future. So getting that pipeline right is critical. And I think that's a hard one at the minute, because we all recognize a traditional CEO role. We all recognize a traditional executive director role, but people struggle to recognize these sort of hospital leadership roles within groups. But we're trying to work on that.
It sounds like I had a similar conversation with the same people on the aspiring chief exec course. Yeah. I think, interestingly, Shane DeGaris down at Bart's in a previous episode kind of made a really good distinction, is let's not be worried about the accountable officer. Or the accountable officer is quite a clear role. If you want to be a great leader, actually some of these roles are exactly that. They're great leadership roles. Actually, don't be in a rush, because his other point was actually you probably have to be in other roles, which I think you said you learned from being in Manchester to be able to do the Liverpool role. You couldn't probably just jump straight into being a group leader like this, because it would be too enormous in many respects.
Well, I went from a sort of exec managing director type role in a group at Salford into then my first accountable officer or accounting officer role as a CEO in Cheshire. And I've said many times, I don't think I'd have been prepared for that in the way that I was, because the elements of the role that I had, the accountability that I had at a point in time, the responsibility for other directors who were senior people who knew their way around stuff, all helped prepare me for the CEO role. I think they're an important part of how things go forward. I think the difficulty is making, how do you manage this sort of wild west of our group's things you can just set up and do whatever you want, because there are methodology to get around, mergers or acquisitions or other structures. And that's the bit I know that NHSC team are looking at all of that rightly. And we'll all say that we've got a model that works, won't we? But, I suppose there's individual circumstance and some learning. And I note every time that we're mentioned in things like HSJ or anything, that the first 15 comments are always sort of, has anyone ever evaluated the group model as to whether it works or not? But it is a really good point. We do sort of evaluations of the things that we deliver. But I suppose, we've certainly had external governance reviews. We've had CQC well-led reviews. And so we've got pretty good assurance that what we're doing is working for patients. And that's, I suspect, all we can do at the minute. But it is an interesting concept because they're so different.
And that's one of the reasons why I did these series of podcasts, because actually they all are very different. But I would say, back to your point, is the nature of how and the structure of how you do a group is really important, because it should facilitate great outcomes and great change, which is what you're describing has happened in Liverpool. If it doesn't, you've got to question why you're doing it in the first place. I think that is worthy of analysis and it is an NHS England regulatory responsibility, I think, to say, is this structure good enough to make the change that we want to happen? But secondly, it's got to be good for patients. And if we can say, actually, things are improved, like you were describing in maternity, I'm sure babies are safer, mothers are safer, staff are safer in that unit now than they were before. What's not to like?
Yeah, I guess it's the traditional thing of when the CQC came, and they were really, I think, open to the discussion, but very fixed in their views of what organisational structure should look like. And I have to say, credit to them, they pushed and pushed and pushed and pushed about why we didn't have an ed-led committee on this or an ed-led committee on that, and why we were doing things in the way that we were doing. But they were also open-minded enough to look at the results rather than just the structures, and concede on points and agree on points that, look, this looks to be having the results that we want to see. We can't find evidence that it's not working. We're seeing that patients are being better looked after. And that's what they're there to do, which is great. But that hasn't always been my experience in years past. So I'm grateful that the recent inspections with the CQC have taken that view. Let's just see what we find, and the results will be based on whether it's improvement or it's not, rather than obsession over how you structure an organisation, which I've certainly seen before.
Yeah. Final thought then, James, from you. What are you looking forward to? What's keeping? I can hear lots of things that are keeping you up at night and whatever. But what are you kind of getting out of bed and thinking, this is going to be our opportunity if we can kind of land this?
I think for us, it's there's always stages to this, Anna. The first thing is sort of getting this over the line in terms of getting us all to that final point where we've got the structures, we've got the clarity around what we're doing. But the big one is our shared strategy. And we had the sort of first cut of that on Monday. And as I said earlier, what was really interesting was trying to take 5 organisational strategies, visions and objectives, and then say, how do you turn this into something that everybody's going to recognise? And the fascinating bit, and Tom, our new Chief Strategy Officer, did a brilliant job of this. He just grabbed everybody's strategies, everybody's vision statements, everybody's objectives, and he really just visually cut all of the things that we all agreed on and used similar language on. And we found that it was about 80% of the strategies that we'd all put together, and the visions that we'd all articulated, and the values that we all said were the same. We might use slightly different language, but they're exactly the same. The things that we all wanted to be better at were virtually the same. So the commonality, the things that sort of bring us together was pulled out. And what that's going to do for us, I think, is really start to say, well, look, it doesn't matter if Clatterbridge have always known it as this, or the Royal have always known it as that. What's important is that we understand where we're trying to get to. And the bit that really excites me is some of this bigger opportunity around research, innovation and digital technology, because it feels like there's the opportunity to make a leap on population health improvement, which often is seen as only the responsibility, I say only, a huge responsibility of those close to neighbourhoods and close to primary care, and that's absolutely right. But there are things we could be doing with technology, with genomics, with testing regimes, with all sorts of stuff in the acute and specialist sector that could massively take a leap in terms of population health. I was looking at some of the results over in Karolinska around what they'd done around early detection of genomic chronic disease and just being able to prevent future disease in their population with simple genetic testing. And how there's masses of opportunity there. but you can't do that with 5 digital systems that don't talk to each other.
Yeah.
So there's some really big stuff on the horizon, but for now it's basically, let's just keep getting us together, build that strategy, start to talk in a common language, and hopefully just keep incremental improvement will be good.
James, it's been fascinating. If I could draw your themes together, I mean, look, 5 separate organisations, hospitals, all doing great stuff, but doing things separately by themselves, the need to bring them together. I thought you talked, some really interesting things about how almost you created the group arrangements and group structure even within one organisation to delegate, to have executive teams, to have responsibilities, and are always balancing that scale size against local management, local identity. Clearly, your populations love your local hospitals. They love your specialist hospitals, the name, the heritage, and you're going to keep that and run those through. And I thought, some lovely and impressive elements on how to do governance well. The governance is a bit of a dirty word at times, isn't it? It's like governance is a cost, but what you're saying is no, investing in the right governance, your 5x5x5, looking at controls, really laser sharp on risk management, the controls that actually avoid us happening actually improves things and avoids harm, and it allows boards to be more effective and takes out time. And I think that's a really good point for us all, is actually how we can do that. And then look into the future. There may be more, but actually it's got to be right and it's got to be well, and you will develop how you're doing. And James, I take my hat off to you. I mean, talk about a set of juggling across your groups with your teams. I mean, you must have a fabulous team, and you just sound so super well organized. But I'm sitting there thinking that's a man who is proud at what his team deliver.
Yeah, absolutely. And the great bit of that has been that with every organisation that comes on board, the strength of that team has improved. There's some brilliant people in these organisations who, reveal themselves, don't they, at these times? And you just think, we've got such strength and depth here of people that this is brilliant. It was just trying to get us all pointed in the same direction, really.
Yeah. James, thank you for your time. Thank you for joining me on Leadership and Culture in Healthcare. It's been a delight to listen to the story and the future for Liverpool.
Enjoyed it. Really appreciate it. Thanks, Matthew.
Thanks.